Okay, so today we're going to talk about largely more late preterm, but preterm and late preterm kind of considerations. So, what's our group of interest to sort of circle the late preterms for today, or LPIs, late preterm infants, 34 and 0 to 36 and 6. I think that there's a lot of great helpful resources, but these babies are ones that are like great imitators. They can sometimes look so much more mature than they really are in real life. And they can get into a little bit of trouble because of that. So I wanted to talk about the immediate post-birth assessment. So certainly for these babies, we're going to allow for delayed cord clamping unless we have clear contraindications, maternal bleeding episode or baby is not responsive. But again, we should do, warm dry stem as much as we can for the first, 20 to 30 seconds to really assess whether that baby is actually not responding to interventions. If needed, perform NRP, but we will talk about that was one of the curriculum pieces that people had asked for was NRP refresher, if you will. So we'll go over all the details of that at a later session date. But the goal would be to keep these, infants who are stable skin to skin with their mother or their birthing parent and latch at the breast as soon as possible. Keep in mind they have limited fat stores. So we're going to want to make sure we're utilizing nice warm blankets and keep the room temperature a little bit more comfortable for them. Obviously, you're going to check vital signs, perform thorough exams, and then let's get all our measurements and plot them on the right curves. So for babies less than 36 weeks, we should really be using the Fenton growth charts. And if you don't either have an EMR or have Fenton built into your EMR, you can use PD tools. And I can put that in the chat since I realized I forgot to include that. And there's a Fenton growth chart on there that you can follow. And then WHO growth charts for babies that are older than 36 weeks. So here we go. Let's talk about kind of common complications that we see. So common respiratory issues, because again, these babies are a little bit immature, including their respiratory system. So RDS, again, the younger gestational age, the more likely you are to see that. TTN, they just have less ability to sort of reabsorb or reclaim all of that fluid in their lungs. So you're going to see a little bit more preponderance of TTN. And many of these patients some more of these patients may be delivered via C-section in the hospital setting. So they are more likely to have TTN as well. And we can see some apnea for some of these babies as well. So something to really kind of monitor and look for closely. Certainly, if you're having issues, CPAP is the first place to start. And I recognize that for many people who are in, lower level nurseries or would be outpatient, you wouldn't be able to do that. But CPAP would be the place to start and then work on transferring as soon as possible. And you're going to titrate your oxygen saturations on your right hand or wrist, so preductal, to be 90 to 95. Late preterm infants have less adipose tissue, so they're less good at insulating themselves and generating heat. And so they also have much more heat loss due to a larger surface area to weight ratio than an older baby would. So that is something to keep in mind, that they may get cooler faster. Kangaroo care should be encouraged. We should be encouraging this with everyone really as much as possible, and that will help improve temperature stability. Ideally, getting that room temperature up. I will say I cooled my own child out of a normal temperature when, of course, I during labor said, "I'm so hot, can you turn down the room temperature?" And they did. And then everyone forgot to turn it back up, and I didn't ask and wasn't thinking about it. So I, the neonatologist, had a room that was too cold for my own baby. And he was not a late preterm kid. He was a term kid, but still couldn't do it. So consider, increasing the ambient temperature of the room, especially post-delivery. Once mom should be a little bit more comfortable. And avoid drafts near windows and vents. Swaddle the baby comfortably. And then keep in mind, some of these babies may require a radiant warmer or isolette. A lot of these babies will have poor feeding. So especially, these 34, 35 weeks. Um, we know that sex swallow breathe is immature and they have low oromotor tone, so they're just unable to really extract the milk as well, which puts them at risk for dehydration, jaundice, hyperbiliary, failure to thrive and readmission, and unfortunately as well, are more common in these babies. So we should allow for early unrestricted access to the breast as much as possible. And then a lot of parental education on what feeding looks like, right? What are cues? How often do we need to feed? Not allowing babies to go for longer periods, optimizing the position of the baby latch, talking about duration of feeding. So not allowing these babies to feed, ad infinitum, but sort of trying to limit their caloric expenditure. And then consider things like breast compression during direct breastfeeding. That can really help get that hind milk out a little bit more and help the babies that are a little less vigorous at the breast. I will say that nipple shields are a really helpful tool, but they also can cause more long-term issues. So just keep in mind, if we're going to start recommending nipple shields, we need to really be having more touch points with those families so that we can make sure that things are going well. Because long-term, they can have issues with milk transfer and, ultimately inadequate milk supply if we're really just sort of riding on mom's letdown, if you will. I tell families all the time, as well as all my residents and fellows that come through, that sex, swallow, breathe, and just the feeding maturity is a big bell-shaped curve. It is sure we see sex, swallow, breathe generally around 34 weeks, but and this just goes to show that our gestational age dating is never perfect, right? Unless it's IVF, but it may be plus or minus around 2 weeks. So, that may be some of this bell-shaped curve piece, but also then we know we have some germ babies who haven't figured it out and eventually do. So generally around the 34-week mark is when you're going to be expecting to start to see feeding cues and some sex, swallow, breathe reflexes. And then that will mature as babies get a little bit older. So when they're right around the 40-week mark, they have about one suck to one swallow at a time. But then as they get a little bit older, it will eventually be, multiple sucks to a swallow. I just like this is from Paula Meyer. I just love this because I think it's just an interesting thing. So this is like polysomnography, but watching what is happening in terms of SATs breathing and watching the sucking behavior. And so you can see that. I'm so sorry. I was trying to. Can you see my cursor? I'm not sure if you can. Yeah. Okay. So these babies here are sucking, and this SAT remains stable, which is great. But then they start to breathe, sort of differently than the sucks. They're breathing in between here when they're not sucking, and they have these sucking bursts where they're not breathing so much. This baby is unfortunately having some sucking bursts and then is desaturating following those bursts. So this baby needs some more pacing, which is a pretty common thing. There's also a lovely paced feeding video. If you're trying to help families learn a little bit more about this and show families, it's on the IABLE website, IABLE. And it's a quick little, I think you can actually even YouTube IABLE paced bottle feeding, and it will get you there. And then this baby has a huge long burst of sucks and is also breathing throughout. So it just gives you kind of a sense of the spectrum of some of these babies. These babies need to be monitored really closely in terms of feeding and growth. As I mentioned before, these babies can be great imitators. So do not be fooled by them. They can look like they're, and I have so many parents who are not experienced with breastfeeding, or even for that matter, feeding until they then take the bottle down and they go, oh, they didn't actually take something, but they're like, they're taking it great, but they're actually not really transferring a lot of times. So keep those things in mind. Follow breastfeeding assessments. I think it's great to have, touch points where you're looking at the latch or nursing is looking at the latch if you're not experienced in directly breastfeeding, and assessing those dyads. But looking at feeding logs, intake and output, certainly if they're in the NICU, if you're in a NICU setting, then you're going to have a lot of data to review, but I also do my best to try and not NICUize these kids if they are doing really well. So letting them go to the breast more frequently. Many late preterm infants need to be supplemented. So oftentimes we're seeing things like triple feedings where they're going to the breast, then the breast is getting pumped, and then they're getting fed that pumped breast milk, or they're getting fed the breast milk that was pumped at the previous feeding session. So, but that is a really laborious process that is a lot to ask for families. So we need to keep in mind that we need to work with families over time to start removing some of those triple feeds, because, we talked about maternal mental health, and that is a huge problem in terms of not allowing people to get enough sleep. As someone who has triple fed my own baby that didn't maintain his temperature, I will say, I was getting like 30-minute bursts of sleep, around the clock, and that just did not go well. So that can be really challenging for parents. So keep that in mind. And I think you also need to have about 10 sets of hands if you're going to do triple feeding, and especially if you're doing a SNS or supplemental nursing system where you're having a little tube help to feed some of that pumped milk at the breast. It's just a whole nother thing. So keep that in mind, to have hands around to help people. Some babies may need formula, or for that matter, donor breast milk, if that's an option for people. The youngest infants will likely need fortification to provide additional calories, protein, calcium, and phosphorus. So keep in mind, these babies that are born, 6 weeks early, that are 34 weeks, they have missed out on 6 weeks of calcium phos secretion, which is really high in that last trimester. And so to help, get that accretion in, and get adequate levels of calcium and phosphorus, that's another thing that we want to encourage. And then really low threshold for PO gavage feeds. As I mentioned, these babies can be great imitators. So if they're, looking like they're doing what they need to do, and then they're not gaining weight, they have excessive weight loss, they have hypoglycemia or other problems, then I think we really need to have a low threshold for doing PO gavage feeds for them. And then with that in mind, as I kind of mentioned before, treating them as much like an older baby and not trying to NICUize them. So the total fluid volume being a little bit less than you would have another more preterm baby being. The most recent AAP paper we have on late preterms from the Committee of the Fetus and Newborn is actually from 2007. So it's quite old, but they do recommend considering delayed discharge if weight loss is greater than 7% below birth weight. And, when you think through it, realizing how challenging feeding can be to establish at home when you're outside of intensive lactation support, or how problematic their feeding can be and how they can be these great imitators, we want to just watch them a little bit more closely. And then consider vitamin D and iron supplementation. Everyone should have vitamin D, but the youngest ones should probably also have iron supplementation as well. Many babies born preterm, especially late preterm babies, may be caused by Preterm or prolonged premature rupture of membranes, which increases the risk for infection. So certainly looking through the birthing person's GBS status, and if they received any adequate or adequate intrapartum antibiotic prophylaxis, that can be very helpful. And then thinking about a potential blood culture and empiric course of antibiotics when clinical concerns arise. So for me, if you are having prolonged respiratory support needs, so beyond 6 or so hours, I'm starting to wonder, this doesn't seem to be very transient any longer. I can't blame this on TTN. Do I need to think about a pneumonia or something else? If they have temperature instability, which again, some of these things are challenging because they are like harbingers of a late preterm baby, right? Temp instability, apneas, things like that. But you start doing too many things at once, and I start to get concerned that there could be something underlying all of that. Things to keep in mind. Hypoglycemia is very common in these gestational ages. They have immature hepatic enzymes and low glycogen stores, and you should implement a screening protocol for hypoglycemia. This is a lot, but you can review it on the slides that will be up on the IECO platform. But this is ours from UC Davis. So this is the newborn nursery one. So this does say for babies greater than or equal to 35 weeks, simply because babies less than 35 weeks are not in the newborn nursery. But we essentially use a very similar approach in the NICU as well. So I'm not going to spend a lot of time on this. This resource will be available to you. It is unfortunately, it's not on the PCG, which some people may know is the Pediatric Clinical Guidelines website, and I have a slide for that with some of that information on it later. This is more of one of our internal policies, but it will be on the slide, so you'll have exposure to it if you need. Jaundice or hyperbilirubinemia, late preterm infants are 2 times more likely than term infants to have elevated bilirubin concentrations. The AP guideline is super helpful. I will say it's very dense, and it does take a little bit of work to get through, but I'm going to try and help remind you of some things. And then just a quick reminder that for infants less than or at that 34-week mark, utilize Stanford Preemie BiliRex. So the one thing that and I have the link on this slide, the one thing that I will say is that they don't want you to use that before 48 hours of age. So I call the babies that are less than 48 hours of age, and in that young group, they're in like this no man's land, this bilirubin no man's land. So I do look at it, because if they have already exceeded the threshold of where that would be allowed at 48 hours, well, that's problematic. I also review these nomograms from the most recent 2022 AAP guideline, which are built into our EMR. And if they're not built into your EMR, I have some slides for BiliTool just so you can see what those look like. Super helpful resource, which has a lot of information on it as well. And then I do 5 times their birth weight, worst case, and sort of see also has that. But for bigger babies, it usually doesn't cross that threshold without crossing one of the others, but those are things to keep in mind. We should definitely screen for bilirubin levels by 24 hours of age, but sooner if there's maternal anti-erythrocyte or anti-RBC antibodies present. We should be assessing for risk factors, which I've included below. Plotting the bilirubin on the appropriate nomogram. It's best if it's built into your EMR, because then it just does it for you. But if it's not, then I'll show you the BiliTool that you can use as well. And then really keep in mind, if these babies are hospitalized, once they are discharged, they will need more follow-up because their bilirubin can sort of linger a little bit longer as an elevated number compared to their term cohorts. And then if needed, really, we should be providing phototherapy in the birthing person's room. And then we should escalate care PRN. And there's a lot of information about that within that AAP document that I have. This is just a screen grab from BiliTool. So it shows you, how you enter in the data here. And once you enter it in, then it will show you the summary of what you entered. So I put in this 36-week gestational age baby that was 24 hours old, had a bili of 8, but did have risk factors as well. And then so it said, if using a TCV transcutaneous bilirubin, would you want to confirm with a serum? Yes, they would give you that, and the threshold for that was 6.5. They tell you, no, this baby does not need phototherapy or escalation of care or an exchange transfusion, and then they give you a link to more information as well. And then what's lovely about this tool as well is it gives you some information for post-discharge follow-up. So if the baby is, 1.4 milligrams per deciliter below the phototherapy threshold, at 24 hours of age during the birth hospitalization with no phototherapy, measure the TSB in 4 to 24 hours. So it gives you some options to use. Home phototherapy, if, guidelines are met, or delayed discharge, or consider discharge without phototherapy and close follow-up. So it gives you all sorts of different options. Most of us wouldn't be sending this baby home potentially at that point, but if they needed to go home, then you'd want to make sure they have a clinic follow-up. So All of that stuff is great, and it plots it for you as well. Okay, in the last couple minutes, I want to just quickly go over discharge and follow-up. So discharging these babies, when they're successfully feeding ad lib, either via breast or bottle, and then taking adequate volumes in a reasonable amount of time. So as I mentioned before, we don't want them to sort of linger on these feeds for a very long time, expend a bunch of calories. We want to make sure their weight loss is not excessive, or if for some reason they've been staying in the hospital for a longer period of time, we want to make sure that their weight gain is demonstrated, or at least plateau is demonstrated if it's just a short period of time. That they're maintaining their temperature without assistance, so not needing any kind of external heat source, and then they're in safe sleep conditions, they're avoiding stooling, and they have stable respiratory status, not needing any respiratory support, and are without ABD events. We do have an ABD event sort of guideline on our PCG website as well, which I can show you the link for in a second. And you're going to want to follow up within 48 hours of hospital discharge, really watching that weight super closely, monitoring their growth very closely, monitor bilirubin. As I mentioned, their bilirubin may continue to linger elevated for 5 to 7 days. So if they're discharged at 2 to 3 days of birth, then they're really going to need some more follow-up bilirubin levels typically. And then I already mentioned this, but a good reminder again to wean the triple feeding, as it makes sense too for that baby. And then long term, many of these babies do not have many complications, but there is a slightly increased risk of developmental and behavioral issues. So some mild developmental delays and some behavioral disorders like ADHD. So keep that in the back of your thought as you're having these touch points with families in the years to come.